Okay, we're live.
Thank you, Erica. Should I do an introduction?
Yeah, why don't you start, Kim?
Sure. So I'm Kim Bowles, Flat Closure Now, and we have Melissa Jansen and Katie Fink, and we're talking with Doctors Tawari and Kochak about going flat at the initial mastectomy. So we have quite a lot of questions for the doctors, and they've been kind enough to give us an hour of their time. Thank you, doctors.
Our pleasure. Thank you for having us.
Should we go ahead and jump in?
Yes.
Yeah, why don't we go ahead and you start first, Kim.
All right, I'll start at the top. So talking about going flat at the initial mastectomy. This is when, I'm sorry, I keep getting notifications on my phone. This is just, the initial mastectomy, women that affirmatively choose to go flat. So the first question I have is, what constitutes an acceptable flat contour, like a flat chest contour, in your opinion? We see a big variation between surgeons, and we're wondering why that is.
I mean, I've got some thoughts. Dr. Kochak, do you want to jump in, and then I can kind of...
No, go ahead. Why don't you share?
Yeah, so my thoughts are probably first and foremost what I would consider an acceptable contour. If I kind of divide the chest wall into 5 quadrants, we've got kind of the upper inner quadrant, which is the cleavage area. We've got the kind of the lower inner quadrant, sort of the central area, typically where the mastectomy scar is. And then you've got sort of the lateral part of the chest. That's 1, 2, 3, 4, and then the trunk. So in those 5 areas, if I were to kind of categorize the most problematic area for patients, I would say that it's the trunk with a lot of excess side tissue. I think almost always that can be addressed in an effective fashion where patients aren't left with a lot of excess, hanging skin. I think that the most problematic area to achieve a flat closure, particularly in a single stage operation, and very much so in a explant flat closure, is the central scar area. And that's where we oftentimes find a step off from where the pectoralis muscle ends and kind of your lower chest wall begins, kind of those lower zones I was talking about. And the reason that's so problematic in the explant patient is oftentimes the pec muscle has been released. And so then it window shades up and it leaves this area of contour step-off deformity. I think that's less true in a flat closure at the time of mastectomy. But I think certainly in the explant patient, that's a big problem. When it comes to that medial zone, kind of that upper inner and lower inner zone, that's where you end up with a standing cone deformity, also known as a dog ear, also known as an angel wing, that you've got to be very careful that you don't extend that scar across the chest wall. Because if that scar comes across the sternum, it can look very unnatural and can become also a bit hypertrophic, very prominent. But at the same time, you don't want to leave a lot of fullness there because it looks unsightly. So I guess those kind of 3 areas I think are the ones that kind of draw our attention the most for a good flat closure. I definitely think that the lateral area at the side part of the trunk is the one that patients find most problematic, and it's probably the easiest to address, to be honest.
But I will add, it is very different if it's done at the time of the mastectomy versus, say, when the patient's in our hands with an explant procedure. At the time of a mastectomy, really chasing those lateral defects on the side of the chest can become very difficult. Sometimes we have to actually reposition the patient into the lateral position, and adding that to a procedure where you're already doing mastectomies and sentinel nodes and all that stuff sometimes isn't even feasible. That's why really this can sometimes become more of a plastic surgery process than something in the hands of the breast surgeon who's doing the mastectomy. So I think it's a very different outcome when we see them done at the time of the mastectomy, often without a plastic surgeon involved, and versus, say, in an explant surgery where we're taking implants out and chasing that tissue off to the side of the chest. Because I often reposition the patient, especially in a higher BMI patient, to chase those areas back all the way to the back, sometimes to the scapular region, to the shoulder blade.
Yeah. We've seen the scars extended under the arms in order to address that hanging excess tissue that women are sometimes left with at the sides. That seems to be the biggest defect, as you say, that we see. But we see it all the time, and there must be a disconnect in somewhere where the patient is not expecting that to remain. Like, they're expecting that to be removed, but then it's not removed. I guess my biggest question...
Is that something that maybe somebody, you could tell us right now how somebody could address that with their doctor before they have their surgery, so that they can figure out, what is the best way to address that with their doctor?
Well, are we talking, are these people that are being seen by a breast surgeon or by a plastic surgeon?
Almost every time the mastectomy is done by a general surgeon or a breast surgeon. And there's almost never, in my experience, there's almost never a plastic surgeon doing the closure.
Yeah. This is a tough
one to ask about, but yeah.
This is a tough one. I think, and we've touched on this in the past. So I guess I can answer that question in two ways. One is from the general surgeon's perspective, and at least what I think is the general surgeon's perspective. And the second is from what I think is the patient's perspective. So general surgeon's perspective, I think their goal, of course, is to do a good oncologic operation to remove the cancer. But at some level, there's a certain sentiment or teaching or training that if they can do these with shorter scars, that they're doing the patient a favor.
Yeah.
Because they're doing a relatively more limited incision for a more limited scar, and that's a good thing. I think what they don't appreciate, what isn't fully kind of a part of their training and their experience, is what we learn at a very early level in plastic surgery, which is oftentimes you're trading form for scar. So a great example of that is a breast reduction surgery. If a lady comes in with very large, pendulous, uncomfortable breasts causing her neck pain and chest pain, what we're doing is a inverted T, wise pattern type incision that leaves scars, but the hope is you will then leave the patient with nicer, more shapely, less cumbersome, less uncomfortable breasts. So you're trading shape and form for scar. And that's kind of very fundamental to plastic surgery. But to be honest, it's a little counterintuitive, really. Most people don't think that leaving bigger scars would leave you with a better outcome. So I think that's part of a fundamental disconnect that most general surgeons have as opposed to plastic surgeons. From the patient's perspective, I think it's hard for a patient to oftentimes really communicate this concern to breast surgeons. They don't fully have the vocabulary, or they don't fully have an understanding whether that's going to affect them or not. And on the patient's list of priorities, their cancer surgery, their lymph node dissection, potential chemotherapy, potential radiation treatment. This is oftentimes not something that they're even thinking of at the time of their initial first or second consultation. It becomes an issue only afterwards.
I don't really think that we've come to a place where when patients see a breast surgeon and the discussion of reconstruction comes up, the plastic surgeon gets involved. I don't think we're at a place yet where a flat closure is considered reconstruction by enough people. And so this concept of involving a plastic surgeon for a flat closure, I just don't think, obviously through this type of forum, through this type of effort, I think it's going to start to become more, I think people are going to begin to understand that that is an option. It is a reconstructive option. I don't think it'll ever fall in the hands of the breast surgeon. I think if we leave it in the hands of the breast surgeon, I don't think it's even fair to expect that person to be able to handle that type of procedure at the end of what could be already a very taxing and arduous procedure. That's why it's so nice. We always, when we trained at MD Anderson, we always thought of the removal of the cancer as the ablative or the sort of the extirpated part, the removing of the cancer, and then the reconstructive piece. We always wanted two separate teams involved with those, mainly because there's a very different focus in those two activities and those two things. And so I think as we talk more about this, we may reach a point where a flat closure becomes a reconstructive option. And just like other reconstructions, which can be done at a delayed setting, they can also be done in the immediate setting. This will also, I think, fall into the same type of thing where it can be done immediately or in a delayed setting.
Which is actually what one of our goals really is with flat closure now. We really believe that not only do we need that to be specified as a medical procedure, but also that physicians are getting compensated properly for that procedure.
Yeah, I think once we see it as part of the reconstructive ladder, as we like to kind of put in our field, I think then we will start to see more referrals for that. And I think one of the great things about social media and the internet is the ability to drive, the dissemination of information, and then the patient can drive this type of thing, which I think is going to be critical here, because I think it's going to require the patients requesting, a consultation with a plastic surgeon, even if it's for a flat closure, which is a reconstructive procedure, at least in our minds.
Yeah, I think that's such a critical point that Dr. Kochek just made. I think for patients, a lot of patients will come in saying, I don't want a reconstruction, I really just want a flat closure. But it is a reconstruction. It may not be a bra cup volume reconstruction, but I think to think of it like a reconstruction, for patients to ask for a flat closure reconstruction, I think is a message that's delivered and interpreted differently than, I don't want a reconstruction. I think that those two statements, I don't want a reconstruction and I want a flat closure reconstruction, are totally different statements.
Yeah. Thank you. I think we all really agree that, our goal is to start considering it reconstruction. And a lot of people are already starting to use that language, flat closure, which we're pretty proud of. So
yeah, well, actually, I incorporated it into my new patient consultation now, and those are the words I use. Are you interested? Are we talking about a flat closure reconstruction? Are we talking about different types of reconstruction? So I've incorporated that into my new patient consultation. Those words, flat closure.
Thank you.
Awesome.
Thank you.
I really appreciate that.
It's
I think
procedure. Yeah, I'm sorry.
I'm so excited that you can define that, because we want to try to move in that direction with women that come and ask us, like, how did you have that result? What was your surgical outcome? A lot of people look at my scars, they want my surgical outcome. I was a reduction patient, and I think once they have this information and can move forward with the terminology and the questions that we can give them as well, they will feel more confident to go in and ask the plastic surgeons, who up until, well, even now, we're still struggling to have a good dialogue with plastic surgeons that understand flat closure versus implants. And a lot of women, I feel, are very, how do I want to say this? And I want to say it correctly. I feel like a lot of women feel the pressure to put implants in, me being one of them, because I wasn't offered any other options. I didn't have this. I didn't have pictures. I didn't have somebody to stand there and say, you opted out of, you wanted mastectomies and now you're looking for options. So
it's really interesting. Can I jump in before this is very interesting. Please. To say that, because I know we're talking about flat closure, but we see so much on both ends. You know, we see also so many people that weren't offered other reconstructive options, you know, say tissue options or something like that. And now we've got sort of this other side where they weren't offered a non-reconstruct or, you know, a flat closure option, which is reconstructive. But it's because I think one of the most difficult things is really expanding all of the options that exist for reconstruction after breast cancer to, I mean, we almost need to create sort of a menu where every option is put in front of the patient. And that's really tough to do because it's not always that way. You know, you get a very truncated, I mean, it's like going to dinner at a function that's been sort of prefixed and you see like two things. You don't get the whole menu, you know? Right. We really got to create a situation where patients have access to the whole menu. And when we do that, I think then they'll get the full spectrum. And that would be such an ideal situation. I think it'd be a humongous triumph for breast reconstruction.
I love that you use that metaphor because we have been talking about and using the hashtag put flat on the menu. So so it's wonderful that you're also, you know, in the same mindset as us, that this really needs to be an option and made an option. But we should probably get back to our questions, which we're all here for. So I think I'd like to jump in with one of my questions, which is in regards to, I am interested in what you feel the effects of fascia and the disruption of fascia. Do you think that has anything to do with cording and other functionalities that people should be aware of?
That's a great question. So does the removal of the pectoralis muscle fascia at the time of mastectomy lead to cording? I guess the question is, what leads to cording? Do you know, Dr. Kochak?
Oh, please. I want to know. I need to know.
Yeah, cording is a tough one. I don't know if I know what causes it. Do you?
Okay.
My theory is that the disruption of fascia is a possible reason that cording can occur.
Yeah, because cording is, you know, technically scar banding across the chest wall, extending into the axilla. It's not necessarily lymphatic. It's not vascular. I mean, it's scarring. But why do some patients cord and other patients cord? I don't know.
What if you scar like I do? I scar horribly.
Yeah.
Everywhere. One of my biggest concerns when I had implants was, of course, my scarring and how I scar. And any surgery, any procedure I've ever had when I had my C-sections, I remember them cutting this big long rope out of me on my second C-section going, holy moly, look at this long cord of scar tissue you have. So my theory was always that's what my body does.
Yeah,
but I get cording and I have PT regularly if I'm not on top of my game, stretching, massaging, taking care of that.
Yeah, my suspicion is that cording, much like most scarring, as you know, Katie just pointed out, is really, you know, your genetic healing potential. So in general, you know, the lighter skin somebody is, the thinner their dermis, the more favorable their scarring pattern, the thicker their dermis, particularly in Asians and African Americans, the less favorable their scarring pattern. Cording, you know, is always thought to be sort of a scar process, almost like a hypertrophic scarring, which is why we recommend like scar massage. It tends to be in the axilla or the lateral part of the chest, which means I'm not sure if it's related to the fascia. I mean, it very well could be, you know. I think that a lot of breast surgeons are taught to remove the fascia. A lot of breast surgeons are taught to leave the fascia. And I don't really know when they remove it and why they remove it, or when they leave it or why they leave it. We've just seen variation among different breast surgeons as to how they do the operation. I think most, generally speaking, remove the fascia.
Okay.
I don't know that even when they do remove the fascia, it's not something that extends really up to that axillary region. So it would be over sort of the central part of the pectoralis muscle. I'm not, again, I don't know. I'm trying in my own mind to think what could be linked to it. That's a tough one. I don't know if fascial, I'm not aware of any study it would be pretty easy to look at, I guess, if we knew what techniques were used, but that's probably the harder part to know exactly what technique is used at a mastectomy. So that would be something interesting to study, certainly.
So with regard to,
I'm sorry, function is a big concern of patients in addition to the cosmetic outcome. These are concerns we've heard from so many different women. Fascia was a big one for some reason.
Yeah, truth be told, there isn't really an indication to remove the fascia. Maybe in a tumor that's abutting the fascia, within a few millimeters of the fascia, it's reasonable to remove the fascia, at least in that area. But I don't know if there's really an indication to remove. The fascia on the pec muscle isn't particularly thick, but I mean, it's a clear plane. And I don't know that it's necessary to remove it ever.
well, when you're talking about different skin types, that sort of segues into another question with regard to radiation. What do you recommend when working with people who have had radiated skin?
Ooh, I've dealt with several cases of this in people who have had flat closures and then had radiation, and we can sometimes see a lot of tethering of the scar, a lot of fibrosis that limits the range of motion of the extremity. And I've had a great deal of success in bringing these people back afterwards, after several months after the radiation has settled, and performed serial rounds of fat grafting, not for reconstructive purposes, but strictly for being able to take that tissue, which has become very fibrotic, and create a much less fibrotic environment. The tissue ends up becoming more elastic. It becomes softer. I've even had patients who had literally osteoradionecrosis with open wounds that weren't healing, that I've fat grafted serially around the wound and have been able to actually come back after a few rounds and excise the entire thing, advance the tissue, and close it. So I think fat grafting has an incredibly useful role. And again, this is afterwards. This would be in the extended, recovery period, not at the immediate setting, but it would have to be after the radiation, because it brings tissue, little droplets of fat that have not been irradiated. And these fat cells are non-irradiated fat cells. And there's been work done, out of some of the Italian groups that have put out work that have shown how dramatically fat grafting into an irradiated field it can reverse some of the effects of radiation on the tissue. So I'm a firm believer that fat grafting is a very powerful tool to help really reverse the effect, if not at least improve the effect of radiation, and especially in the flat closure population, for sure.
So then if somebody needed to have, say, they wanted to have corrective surgery because they had dog ears, but they've had radiation, you feel that fat grafting would be a way of being able to help with regard to that?
Yeah, I mean, I think you could take a patient if they've got significant amount of fibrosis and the tissue is just not sitting easy, in a smooth and contoured way. I would bring them for a couple rounds of fat grafting, and after serial fat grafting, I would bring them in for an excision and closure, knowing that there's a much higher likelihood that we'd be able to mobilize that tissue and actually get a much better closure. Will it be perfect? Maybe not as perfect as it would have been without radiation, but I think we'd be in a much better place.
Wonderful.
Yeah, the other thing
the
I'll
more
say,
I hear you guys talk about this, the more I'm convinced that it's not the right thing to divide patients, to sort of, divide patients into those that want reconstruction and those that don't. Those that do want reconstruction have access to plastics. Those that don't want reconstruction, as it's typically defined, don't have access to plastic. Fat grafting is something that only plastic surgeons do, right? That wouldn't be
There wouldn't be a surgeon. That'd be a plastic surgeon.
yeah.
I'm just, in terms of patients having access to I mean, some of these functional issues, if they can be effectively addressed, but only by a plastic surgeon, and the patient never sees a plastic surgeon, that's definitely cutting off, you know, resources that they might really need and might really be able to use. I'm just thinking about it.
Yeah, the other point that I'll say about the radiation is, you know, part of it is the radiated skin. Part of it is a paucity or a lack of skin. So radiation is essentially a burn. And, you know, if you have a burn in an area of mobility, imagine the elbow crease. What happens is the elbow contracts with a burn in that area, and you can't extend the elbow. So it's the same with the axilla, which is also a joint, also a crease. And if you have a burn in that area, you can't extend the joint. Well, how do we in plastic surgery deal with a burn? We recruit healthy, non-burned soft tissue into that burned area with, let's say, a Z-plasty. That's how you typically deal with a burn contracture. Well, you can't really do a Z-plasty in the chest, but that's where a autologous reconstruction with a DIEP flap comes in. And the thing that we'll see the most frequently in people who've had a irradiated chest wall and have an axillary contracture after a DIEP flap is an improvement in their range of motion, because what you've done is you've released the contracture and you've replaced it with healthy, soft, supple, non-irradiated skin. So, you know, for a lot of the patients who come in with a radiated chest wall, you know, we do talk to them about a DIEP flap, not only for the aesthetic piece, but really from a functional standpoint. It gives them a much better functional outcome because of the replacement of non-irradiated skin.
So this is an interesting question to me. You can do that without inserting an implant as well.
Oh,
You can do
absolutely.
it with some fat grafting to get a nice flat contour as well.
Yeah, I mean, you rarely need an implant underneath a DIEP flap. I mean, unless the patient's very, very thin, very low volume, or just desires to be bigger. But it's not that typical to need an implant with a DIEP flap.
Okay.
But again, there we're using the DIEP flap for a functional outcome, even more so than a aesthetic outcome.
Right. Okay.
So that would actually lead to another question, which I think is on Kim's list with regard to Goldilocks.
Oh yeah. Yeah, do you guys have any experience with the swim procedure or the Goldilocks mastectomy? It's something we've heard a lot about recently.
Yeah.
What? I don't know what that is.
Oh. There is an article we
Well,
should
that
send
answers
you.
my question.
Yeah. Well, let's move on.
No, I guess it's
Enlighten us.
What is it called? The Goldilocks procedure?
It was developed in
You're cutting out, Kim.
Yeah, it's where they use that lateral tissue and to create, you know, a breast mound, or at least, you know, avoid concavity. They sort of, I don't know if it's rotational or what they do, but they use the excess tissue at the lateral chest to
it's like they turn it onto itself. Yeah.
Yeah, the lateral chest wall tissue can be advanced or rotated into that area multiple different ways. It can be based on vessels that are perforating into the area, or it could be advanced, what we call with a VY advancement. There's different ways you can work that tissue.
So yeah, I've done this procedure. I didn't know.
Someone put a fancy name on it, which is cute, but
I didn't know someone somebody decided to put a marketable name.
It's always good to put a cute name on something.
This is a classic. This is a classic example of something that everybody already does, and then someone's decided to give it a name. So yeah, this is really only appropriate in fairly large breasted patients with a lot of redundant skin.
Okay.
Where let's say you've got a large pendulous breast, you'll do essentially that anchor incision like you do for a breast reduction, and they would do the mastectomy through that incision, and then you deepithelialize a lot of that tissue and kind of invert it on itself.
Which
to give it the
means remove the skin.
Yeah, it's basically it's like an adjacent tissue transfer, basically. Yeah.
But the take home
what
point
is this
here.
called?
The take home point here, though, is that given any specific sort of situation, we will always look at sort of what tissues available and how we might use, for lack of better phrases, spare parts to be able to make things work out in a better contour. So all of these are spare parts types of things where we utilize our spare parts, things we might otherwise cut away and get rid of. Instead, now we're using it to maybe augment some of the soft tissue so that we don't end up with a crease under a scar. Like Dr. Tawari just described, maybe we would use the inferior lower part of the mastectomy skin and bury it underneath the closure so that it creates padding.
If you look on our website under the explants, we have a video where we do essentially a modification of the swim procedure in a patient that's had an explant, where we deepithelialize the skin, invert it on itself to then create that type of closure. Guys, I'm going to step away for just a moment and take a phone call, and then I'll come right back.
So I'm wondering if I had that, I'm going to have to ask you, except my plastic surgeon is no longer there. And that also brings in another question when you're talking about.
1 second, Dr. Taiwari, why don't you mute your mic?
I just muted him, I think.
Oh,
Let's see if it works. I tried. Yeah, I did. Look at that. I can mute him. Can I do this in real life?
Sorry about that.
These kind of go into the next questions that we had when you're looking at patients, and as you approach them, they also are like what I would consider like a piece of art. You are looking at breast size, body size, weight, height, and all that. And then when you're talking about this, the general surgeon isn't going to do it, or is it a plastic surgeon when you are considering like what type of shape are you going to give this woman with her flat closure? Like, are you going to do a V? Are you going to do the horizontal scars? We've seen those. We know that my scars come from a reduction, but how do you decide with each patient what is best for her?
I think you just kind of painted the exact, to try to algorithmize, if that's a word, to put it into an algorithm. Every time I've ever tried to put breast reconstruction into an algorithm, it's incredible how many components of thought go into. There are so many little. You listed about 10 things, and that's probably 10 of 100. Like that doesn't even account for several of the patient factors. Like, skin quality is something that's so hard to quantify, right? There's turgor, there's elasticity, there's
what does turgor mean?
The thickness of the dermis, how the turgor usually refers to how like bouncy the tissue is. There's so many different things that I probably can't even put words to anymore that just happen as an assessment. And all of these things are going into the thought process, but beyond just the point when I see the patient and say, here's what we might do. You also have to retain a great deal of plasticity in how you approach the case at the time of the operation, because something that you thought might work may not be the exact right thing on the table. So you have to be prepared to modify your plan based on your experience and your understanding of how tissue might settle. And that's why, we generate plans that then we often, have to modify based on things that we see and find at surgery. And that's the way we end up walking out. We don't walk out, with a subpar result on the table. That's when you stop and you say, what else can I do here? What can we do differently that might make this just 1% better? And I think it's a very tough thing to convert into an algorithm. I wish I could paint it all out for you and say, if this, then that. But in reality, it really does take a great deal of you're assimilating so many things at one time at the time you assess them, and then you might even change that. So I guess it is the art and the practice.
I appreciate that, and I understand that. and we go back to, we mentioned it in the very first video call, and that was the communication between patients and their surgeons is vital. So one of our goals is to give enough information and questions so that that communication can happen. I didn't have a lot of communication with my plastic surgeon. I didn't have this dialogue, but thank goodness he was an amazing surgeon. And I guess he told me a lot of things that would happen when I explanted. They didn't happen. I was extremely large breasted, but I had a reduction. He thought that I would have, because I'm tiny, he thought that I would have some concavity. I'm really curious about when we go back to talking about the large breasted patient again. I know there's also a lot of different body shapes and sizes as well, but we hear all the time, if you have large breasts, you cannot get a flat closure. You will have a lot of skin redundancy. You know, the only way, we've heard that somebody said, their surgeon said the only way that they could do a flat closure is if they took the incision straight across the chest. And I don't know why that is. To me, it seems like it would take away from that pouch in the middle. I can't remember what it's called right now. But my question would be this: aside from all the other factors, when you have a very large breasted patient, do you and can you expect for that person to have a flat closure, a good flat closure?
I think it depends on if we're talking about an explant patient or an immediate at the time of the mastectomy.
Okay.
I think if it's at the time of the mastectomy, it really depends on how you design the mastectomy. So if you design the mastectomy like a Goldilocks type procedure where you have an inverted T is how you address that skin redundancy without extending the scar across the midline.
Okay.
So you'd have to work with the breast surgeon in a Oncoplastic type approach where you design the mastectomy incision, as we oftentimes do in this scenario with our breast surgeons that we work with an inverted
like a
T
breast
type
reduction. It's very much like a breast reduction.
Okay.
You just imagine a breast reduction. You reduce some, you just keep going, and now you've reduced all the breast, and you've managed to take it all the way to what would be a flat closure.
Yeah, it's the same incision pattern, but
Right.
Same concept. Yeah.
But if you don't, and your average general surgeon is not going to be comfortable doing a mastectomy through that type of incision without the input of a plastic surgeon.
Okay. So interesting. I've never seen a unilateral.
So that brings me to a very blunt
Yes.
question.
Oh, go ahead. Go for it, Kim.
My question is, for a patient that wants to go flat at the initial mastectomy, who wants to be done in one surgery, and obviously you could spend 8 hours in the OR trying to get it perfect, you know, and then there's the question of what is an acceptable cosmetic outcome. But for the patient for whom it's very important to be done in one surgery, should they bring on a plastic surgeon for the closure? Should that be the default?
I don't even know if it's as much the closure as it is the incision design.
Oh.
Okay.
I mean, I think
So
it's very reasonable to have a plastic surgeon.
Start to finish.
I think it's very reasonable to have this concept of a plastic surgeon involved for a flat closure. I mean, right now in the field of breast surgery, you know, one of the hottest topics is this concept of oncoplastic reductions. You know, it's when they do a lumpectomy and we do a breast reduction at the same time. So the breast is conserved, and we're brought in to basically the surgeon does, and again, just like Dr. Tawari just said, the most important thing here is designing the breast reduction around where the tumor will be taken off. There are many, many ways to relocate a nipple. There are many, many ways to move one during a breast reduction. And so this is like such a similar concept. I mean, we're talking about basically an oncoplastic procedure where the breast surgeon is there to remove the breast now, and we're there to help design everything from beginning and during to the end to make it end up as a flat closure, at least as ideal as possible. And it's very realistic to always counsel people, you know, during this type of a consultation. If someone comes into me, we always want to try to get something done in one step, but we can't always predict how tissue will settle. So I think it's always important for people to understand you might have to have small revisions if tissue settles unpredictably, or some things maybe after we do a great deal of work can't get it to sit just right. But yeah.
And actually, this is more, it leads me to a couple thoughts. Number one, it's more difficult than one would think, this type of oncoplastic procedure. You know, Dr. Hala Harvey, the breast surgeon with whom we work very closely, she and I, a month ago, visited some surgeons in California specifically to see how they're doing oncoplastic surgery. And so, you know, I've been in practice 15 years. Dr. Hala Harvey's been in practice 15 years. And we still thought it was important to go see other people to see how they do an oncoplastic procedure.
Where in California were you?
San Diego.
Okay, just interested.
Yeah.
I'm in California, so
Yeah.
But I think this whole topic, you know, this whole concept of adding flat closure, reconstruction, I think it fits really well into the oncoplastic arena, because now this is an oncoplastic procedure. And if we can plug it in to the oncoplastic movement, which it should be, which it needs to be, I mean, now we've got a place where it naturally fits, and there's already a dialogue that's happening. And it's not only as a dialogue, it's actually a growing area. And I think it just needs to be plugged in as yet another oncoplastic type of procedure. And oncoplastic means bringing the oncologic and plastic surgeon together to be able to accomplish this. I really think just this discussion.
It's funny because this is a whole
makes it so clear.
This is a whole area. Like oncoplastic surgery kind of became a thing over the last decade, kind of out of nowhere, to be honest. You know, it was being done a lot in Europe, and then it became more of a thing, and now there are textbooks written on oncoplastic surgery. I think what we're talking about here is similar. It's like its own subfield that nobody has really thought about. But I think that it's its own area. And like Dr. Kochak said, where does it belong? It doesn't belong in oncologic surgery. It doesn't really belong in plastic surgery. It belongs in oncoplastic surgery.
I read a statement in a paper that said all breast surgery should be oncoplastic.
Yeah, and I think
a bold statement. I mean, if you're doing surgery with an eye.
Oh, Kim, you're cutting out.
Sorry, I'm going to cut out my video. I get better audio when I don't have the video.
No, still can't hear you.
Yeah, I think increasingly that statement is true, that breast surgery is becoming oncoplastic surgery. And I think the best approaches are where you've got a good team environment, where you've got a breast surgeon with whom you work very closely, as we do with our people here in Columbus, and you kind of like grow and learn together. It's why Dr. Hala Harvey and I, you know, went on this trip together, because we wanted to see how other teams, you know, do their surgery. And I think that type of oncoplastic team approach is something that patients can ask for. Like, do you have an oncoplastic program? Who is your plastic surgeon that you do oncoplastic procedures with? You know, those types of people are the types of people that are going to be more apt to deliver an acceptable flat closure, because they already do it in the context of breast conservation treatment and breast reduction surgery.
Now I'm super fascinated with some of the things that we talked about tonight, and the unilateral approach and how that's going to fit in as well now.
So we're almost at our hour, and there was so many questions that we had for you. So maybe we can do this yet again.
we would love that. This is great.
Awesome.
It's better to dig deep. It's better to dig deep than to superficially pass over lots of questions.
Right. So I think I think there's one more question that I want to get in, because it really relates to what we're talking about with regard to incisions. We get a lot of women who have, they get that peak in the middle, the puckering, which looks extremely uncomfortable. And is there something that Is there something with regard to that? Is it just that a surgeon is not really knowing what he's doing? I say he shouldn't make that assumption, but what is the surgeon doing that is creating that, and how can that result a first time around be avoided?
I mean, I think one of the most important, if it's in the immediate setting, rather than, like an explant scenario, we're going to go back to some of the things we've talked about where it's, again, about design, right? Do you have very large breasts, lax skin, poor elasticity? These are the types of things that would require planning. And just like Dr. Tawari said, it's if you plan the mastectomy from the beginning with the person, you can start to account for those things. Not necessarily that you're going to make it go away for sure, but that's going to make it less likely that you end up with something like that. So I think a lot of it has to do with the planning from the start. I don't imagine that in the explant arena where we're taking implants out or taking a reconstruction out, we have a lot more control in that setting and how we would design that process. So I don't think it probably happens very often in that setting.
So then would you ever do an incision that went all the way from armpit to armpit?
No.
Okay.
I never like to say never, but it would be extremely unfavorable, and I would avoid it at a lot of costs.
Okay.
We've seen it done, and it was said to us that it was done because the patient was large and had large breasts.
I think that's a terrible incision because
remember the large breast thing goes back to, that's a great place where you do sort of, the breast reduction pattern. You continue that reduction to the point, because if you continue to do that breast reduction, you can always continue to pull that excess skin towards the center of not the body, but the chest on this side, right? You can always continue to pull it towards this center, not here. You can pull it here. So that breast reduction pattern just lets you continue to close it just through a triangle. Yeah. If you don't have that planning up front, you then will end up with excess horizontal tissue that will gather, that will create this. A
scar across the chest is very unfavorable, I think, for two reasons. Number one, it's a tight band across the chest. Mm-hmm. Yeah. So from a functional standpoint, people always feel like they have trouble taking in a deep breath because they've got this tight band of scar. The other problem is it's very unnatural looking. It's like a Ken doll without a belly button.
Right.
It's an odd look. And once it's there, it's impossible to fix.
I wondered about that because I had the reduction, but I do get so many women that look at my scars and say that's very appealing to me because it gives the impression that I still have breasts. It gives me some form of shape. I'm now really curious as to what they did when they did my surgery, because I feel that I have a little bit of the swim.
Did you have a reduction before your mastectomy?
That's where they found the cancer, is in my
so
that makes the world a difference right there.
So you were inadvertently fortunate.
Yes,
because
and I know that.
Because you were fortunate not only, of course, because they found the breast cancer at the time of your reduction, but it's because of the breast reduction that your scars are favorable. So you had a plastico-onco procedure.
Yes. Okay.
Not an oncoplastic.
So a plastico-onco procedure, yes.
We just coined a new term. That's ours.
Yeah, there you go. Somebody else took that Goldilocks away from you, but you got that one.
We got plastico-onco.
Plastico-onco is ours.
So,
I think we should go plastico-logic. I don't know. We gotta sound good.
I'm very happy that I ended up with plastico-onco, by the way. I've been this for a long time. Is it fair for a large-breasted woman to ask for the type of scars that I have, or to ask for that type of surgery? Because a few people that have asked me, they said their plastic surgeon wouldn't, or their general surgeon wouldn't do it because, one, they weren't large-chested, or two, they weren't a reduction, or three, I forget what the other one, the scar extended too far back on them.
This goes back straight to, I think, what Dr. Troy was saying. In an environment where there's an established, I'm going to go back to the regular one, oncoplastic relationship. But again, if that relationship exists, it's going to be much easier to have that team approach already. It's very difficult to have someone, to push someone who doesn't have an oncoplastic relationship or program set up to manage to do it, right?
Okay, yeah.
And I'll be honest with you, as far as like, billing and work goes, it's the same as an oncoplastic procedure from our end. It's the exact same coding. It's the exact same procedural terminology. It doesn't, if I do an oncoplastic procedure, I would do a flat closure. It is an oncoplastic procedure. It's a reconstruction. It is.
Okay.
So with all due respect, I mean, I think the answer is it's fair, yes. And it's much more likely that it's going to be accepted if they already have an oncoplastic program or are willing to build one.
Yeah, I think the two take-home messages for me from this conversation is that I think rather than advising patients to say, I don't want a reconstruction, what they should be advised to ask for is, I'm looking for a flat closure reconstruction. And then the second piece is really to kind of understand what your breast surgeon's experience is with an oncoplastic program. Because that, I think, gives it's more than, oh, what plastic surgeon do you work with? Because every breast surgeon works with a plastic surgeon. It's more, what is your experience in your oncoplastic program?
Okay.
Awesome. Well,
yeah, that's a really important point, and I think that's something, yeah, that's very important. Thank you so much for that.
Yeah,
I
and
appreciate your time.
This has been fantastic. So much appreciate it. Yeah, we should probably let you go because I think we're at the hour.
All right, and you ladies, did we, I don't know, Ergin, did we put our last webinar on our social media? What did we decide about all that?
I don't know. I'd love to do whatever we can to connect in ways, in any way possible. I'm going to leave that to Erica.
Yes, it was on, we put it on our YouTube channel.
Yeah.
But we can share it. We also have a special highlight on our Instagram if you guys follow, and I think we should maybe bring some of these questions there and
that would be wonderful.
Put them on the
great,
I love it.
Yeah, and I can share that with you guys as well too.
Yeah, as always, I want to thank Erica especially for kind of putting this together.
Thank you all. This has been great.
She's silent back there, not feeling well, but if it wasn't for her, we wouldn't really, Kochek and I don't have the wherewithal to organize anything.
Stop.
Thank you so much.
Wonderful.
Once it's uploaded and everything, I'll send you guys the link like last time.
Wonderful. And then, yeah, let's do this again, because I would love to be able to ask you some questions specifically on unilateral mastectomy.
All right, we're waiting for the next one.
All right, so maybe Erica, we can kind of figure out a date in the next, month or so and do it again.
That's
awesome.
All right, ladies.
Thank you so much.
Thank you all.
Wonderful. Great. Thank you so much. All right.